Okay, so the purpose of the project that we're going to share with you today was to describe findings from one sort of sub-study within the larger study designed to examine the points of friction within this community doula program in Oregon. So specifically, we're aiming to center the voices of the doulas to better understand the experiences of providing care in a system that is not in any way designed to include them. So for our presentation today, I'm going to start with an overview. I'm going to tell you a little bit about the history of the project and some of the political, economic, and institutional context for the project itself. And then Victoria is going to cover a thematic analysis that we conducted with the doulas. And then Holly will jump in for some interpretations and conclusions, and then we're happy to take questions. Let me pay attention to time here. Okay. So the goal of the program is to improve maternal and infant health outcomes for pregnant individuals and their families here in Oregon. We serve in a 3-county area through the provision of culturally matched community doula services. And so for us, culturally matched means that the doula emerges from the same community that the birthing person does. So they are matched by social and cultural background, shared history, and importantly, often by language. And we have sort of a kind of a guiding principle in our program, and it's that we can't all be created equal if we can't get an equitable start in life. The program is actually funded almost all by Medicaid. And so in 2017, there was a request for proposals, and it was very open. The request said, we're open to any community group or a group of researchers who want to come forward with a pilot idea, and the goal of which we had to meet 2 aims. One was to increase access to traditional health workers, and the second one was to help reduce health inequities. And so in Oregon, as in other places, Indigenous and communities of color, particularly Latinx communities and undocumented individuals in Oregon, have maternal and infant health outcomes that are 2 to 3 times worse than those for comparison groups. And so based on this relatively large body of literature that shows that doulas can be really critical perinatal healthcare workers and help to improve outcomes while also often saving systems money, we put together a proposal that was funded initially in 2018 and then has been extended each year by the Medicaid payer in our counties. And we've also had some additional funding from the American Institutes of Research. So I'll tell you a little bit about what the program goals are and how we've been doing on them. So we initially set out to recruit, train, and reimburse culturally and socially diverse doulas to serve pregnant members of IHNCCO. So IHNCCO stands for Intercommunity Health Network Coordinated Care Organization, and it's the Medicaid payer in 3 counties in Oregon where we lived. So Oregon is really unique among just a handful of states in the US that has passed legislation allowing doulas to become state registered traditional health workers and therefore to receive Medicaid reimbursement for their services. However, many years after the passing of that bill, 5 to 6 years after the passing of that bill, no community health worker doula had actually figured out how to effectively bill Medicaid because it's an incredibly complex and irrational process, it turns out. At the time that our project was funded, there were 6 individuals who had gotten the training required by the state, which is saying something because half of the trainings didn't exist that the state required. So they'd gotten onto the registry and were technically, theoretically able to bill Medicaid. All were white, college educated, and all were monolingual. So one of the goals of the grant was to train a more diverse group of doulas and help them to get on the registry. So since the start of the grant, we've trained 126 doulas, 38 are now on the traditional health worker registry. There's 4 more that are in the process. So 25% of all of the doulas on the Oregon State Registry actually come from the program, and 60% of them come from BIPOC communities, and they actually speak 10 different languages. So by investing in an infrastructure to help doulas get access to training and to navigate the incredible bureaucratic process of getting on the registry, the number of people who are able to serve has increased dramatically. It's supposed to take 3 to 4 weeks to get on the registry. In practice, it takes 8 to 9 months to actually get onto the registry. The second goal was to improve birth outcomes and to reduce health inequities through one-on-one support and advocacy offered by a birth doula. And I'll show you some of our preliminary findings in the next couple of slides. And we had hoped to be able to offer doula support services to all who qualify. So the program is an opt-out program. It means that anyone who qualifies for Medicaid in those 3 counties can have access to a doula. And 2 weeks ago, we started a low-cost program where anyone who wants a doula can be charged somewhere between nothing and $150 and have access to a doula. So we're now hoping to begin providing services to people who don't qualify for Medicaid, but also maybe can't envision paying $1,000 out of pocket for doula care. So far, we've had just over 650 referrals into the program. And so enough to really start looking at some of the outcomes. Additionally, our goal was to train Spanish, Mandarin, and Arabic speaking doulas to cross-train them as interpreters. So one of the things we learned pretty early on in the program is that bilingual doulas were commonly being asked to act as interpreters because the alternative in Oregon is to talk on something that's called the blue phone. And it's a blue phone that's in all of the rooms, and it provides you telephone-based interpretive support while in labor. And most patients really don't want to talk on the phone while they're in labor. And so doulas were inadvertently acting as interpreters without the training, and most importantly, without being compensated for it. And so now we have had multiple doulas do the cross training and are able to provide dual services as doulas and interpreters, especially in Spanish. Our team was incredibly affected by COVID. I will say that the doulas were so ready to find new ways to provide care when we went into lockdown in Oregon, and within 3 days, all of our services moved to telehealth. And so there was no disruption in services except for 6 weeks where we couldn't provide any intrapartum care in any of the hospitals because people were not allowed to bring a support person to the hospital for 6 weeks. So during that time, many of our doulas transitioned to become team leads for community testing and contact tracing, and have continued to play a really critical role in these 3 counties, showing that the skill set that traditional health worker doulas receive is really expandable into other areas and other immediate needs within public health. Our last grant, which we received for 2021, has allowed us to expand services into rural communities. So we just trained 20 new doulas who are providing care in rural communities now. The other thing that the doulas established in our program is 3 peer-led virtual parenting groups. These started during the pandemic when everyone in the program really started to notice a pretty dramatic increase, uptick in scores on the Edinburgh postpartum depression scale, which is a scale that the doulas administer at their last postpartum visit with clients before they transition them into a longer home visiting program. So after a client in our program gets 2 to 4 postpartum visits, there's a warm handoff visit where the doula works with a healthy family's home visitor to transition 1 visit. And then from there on, they can receive up to 3 years of in-home visiting services from that program. So they put together a program for Spanish speakers, for fathers, and for queer, trans, non-binary parenting that are really well attended and have really helped, it seems, to buffer some of the social isolation of the postpartum period that was exacerbated by the pandemic. And I mentioned the collaboration with Healthy Families, the long-term home visiting plan. And we talk about that as moving from birth plan to life plan. And those Healthy Families home visitors often now cross-train as doulas as well. And the 2 most recent services in the program are a collaboration with a group called Nurture Oregon. And this is a group that's funded by the state to provide peer support specialists to pregnant people who are using substances. And so these peer support specialists cross-train as doulas and provide stand alongside services and support to anyone in the Nurture Oregon program. As a part of that, unfortunately in Oregon, sometimes women with substance use disorder who are pregnant are remanded to custody for the totality of their pregnancy. So they're put into jail to keep them from using during the pregnancy. And so this has also opened up over the last year services in the jails in the 3 counties we serve. And the last program is just started, and that's training mom community members. This is a Indigenous Guatemalan language that is on the rise in Oregon, but there are very few people who speak it. And so it's been a challenge for delivering public health services because so few people speak the language. And we just trained our first mom speaking doula in the program. So this doula program serves these groups of individuals, and I highlighted the last one because it allows us to serve everyone. So the grant is focused on providing direct services to Medicaid priority populations and individuals on CALM, which is a Medicaid light, a sort of modified Medicaid for undocumented people. So those are women who are racially or ethnically diverse, speak limited to no English, are considered young mothers, which they name as women under the age of 21, medically high-risk clients, and a majority of the clients in the program actually are medically high risk, women who are underhoused or who are experiencing homelessness, incarcerated people. And then there's this caveat of pregnant people with low or no social support. And we always say everyone could use more support. So this is what enables us to serve anyone who qualifies for Medicaid. And then here's a couple of outcomes from the program. Like I said, 10 different languages spoken. Families that birth with a community doula program, doula are twice as likely to reach their infant feeding goals. And in particular, breastfeeding initiation rates are much higher in the experimental group. So the experimental group is matched to a cohort that doesn't have doula care. And in the doula care group, breastfeeding initiation is almost 100%. There have been 2 people out of 600 who haven't initiated breastfeeding. And the comparison group is between 60 and 70%. So big uptick in breastfeeding initiation. Huge impacts on prematurity. So the comparison group without a doula in our communities have 11% preterm birth rate, and with the doula it has dropped to 4.5%, with the biggest decrease among communities of color. With for BIPOC communities that are served by the program, there's a 2% preterm birth rate, and a huge drop in cesarean birth rates. So the national average is just over 30%. For the Medicaid population that's medically high risk, that's our comparison group, it's closer to 40%. In the doula program, unplanned cesarean rate is just under 14%. So that was kind of a surprise. We knew that they might be improving outcomes, but no one really expected them to have such an enormous impact. Okay, so that's sort of the context of the program. Now, within that, we wanted to understand what is the experience like serving the clientele in this program. What can we learn from the doula's experiences? So I'll turn it over to Victoria here.
Hello, I'm Victoria Keenan, and I'm an MPhil student at the University of Cambridge in the UK. So I'm just going to tell you a little bit about the methods that we used in the research that we've been doing. So participant observation over 4 years, very intensively, and we undertook 18 semi-structured open-ended interviews with the doulas to find out about their experiences. And then 3 of us undertook consensus coding so that we could see which themes were emerging. The doulas themselves will be co-authors on the papers, which is really great. And we're using reciprocal ethnography, where we go back to the participants so that we can really deepen the analysis of the findings. So one of the techniques that we've been using was funded by a grant by the March of Dimes for an innovative art voice project called Measure What You Treasure. So this is a way to collect data in a way that doesn't necessarily privilege the spoken or written word. And the picture that's on the slide there is actually an example of work that was collectively produced by 8 doulas, using art as a unique way to kind of elicit storytelling. So the 3 themes that we'll be exploring today illustrate this kind of common trajectory of doulas that go through the program. So from their initial entry and the training to the challenges that they face, and then their resilience in coping with the challenges so that they can sustain their roles and continue to serve their communities. So theme number 1 is finding the work, narratives of personal transformation. So in developing a community doula program, it's really important to learn what it is that draws potential doulas to the work of serving, understanding their stories and how the experience of being a doula on the program has impacts their lives, can really help with shaping the program's infrastructure to make it as successful as possible. So I'm going to share some excerpted quotes with you from the interviews that we undertook. And this is the first one. This first quote speaks to how many of the doulas were drawn to the work because someone that they know and love was either alone or mistreated in their experience of birth. And that's influenced them in their desire to make sure that that doesn't happen to anybody else. So we have, it's mind-blowing, it's amazing, it's life-changing. I think both for me as a doula and for the individuals I serve. I just think back, I'm getting too emotional. I just think back of my mum's experience and I cannot imagine being there by yourself giving birth, not having support, because my grandma didn't live here. She doesn't have sisters, and just being there, left alone at the hospital to birth. And so every time I'm there for a woman, I think of my mum. I really do. I always think back of her. I think of her experience giving birth and how different it would have been if someone would have been there for her, not only during the birthing process, but afterwards, you know, feeling supported by her community. Now, this quote I'm about to share highlights that many doulas felt a sense of satisfaction, knowing that their clients and the community was positively influenced by their presence and the program's ability to expand access to those who might not be able to afford a doula otherwise. I've loved it. I think that it's changed me as a person. It's become a big part of my life. Being around birth has changed me in how I even kind of operate and go through the world. It's been really wonderful, I think, not just for myself, but for other people. I mean, it sounds cheesy, but it's changed lives, not just the doula's lives, but I think a lot of the clients as well, where they maybe wouldn't have had the experience that they had if it wouldn't have been for having a doula or somebody in this program to support them. So it seems that the satisfaction and joy that doulas derive from their work is a kind of payment that enables them to continue to do the work, even though they are not being financially compensated for their time. So in the article, we spend some time unpacking that not only is the joy that doulas feel in finding the work beneficial to them, but it can also become exploitative as the system gets the benefits from the doula's unpaid labor. So the second theme was hitting the brick wall, birth work realities. So once the kind of initial exciting bit of training and learning and meeting all these passionate and inspiring people shifts into the real world scenario of juggling daily responsibilities and showing up day after day, despite the challenges, the doula's really starting to grapple with what we were talking about at the beginning, this tension between their desire to serve their community and knowing that they also have a responsibility to support themselves and their families. So I've seen this in the doula world. It seems like there are two camps, and one is this idea that everyone should have access, should have a doula, or should be able to access a doula, whether or not they can pay, which I completely agree with. And on the other end, there's this idea that every doula should be paid what she's worth, because we deserve to make a living as well. It's really difficult to find that balance between being accessible and also being able to support yourself. In a community doula program, people come from the community that they're serving. They're not necessarily going to be primarily white middle-class women who have the luxury of doing doula work as a hobby. These are community members who themselves are often eligible for Medicaid. So at this point, when the realities kick in, we call this hitting the wall, because this is where doulas either leave the program or they find ways to stay. And if they leave, it's usually because it's not financially sustainable for them. So this particular doula said, I'm getting paid $150 to go to a birth, $350 for all the care, being on call, being on phones, you know, being there for someone, doing all this extra research, finding out what people need, driving them around, just different things like that. it's not financially sustainable. It's not worth it financially. And so it's not fair to expect doulas to keep doing that kind of work and not paying us. It's unpaid reproductive labor. So in addition to fighting these systems, we're also fighting for ourselves. We're fighting for the clients, but we're fighting for ourselves. And so we need support to do that. When the first bill passed, doulas were allocated $75 per birth for the whole thing. Over time, and it's taken 4 years, there's been a move to $350, and now doulas in the program make $750. So although what they've been paid has doubled, they're still far below what they should be making. And there is evidence to show that doulas are cost effective up to around $1,300. So the program is looking to sort of gradually increase the reimbursement rate. The third theme is finding ways to stay with the trouble, building community. The people who don't leave at this point, let's be honest, the honeymoon phase is pretty much over. The hard work of moving through this system that is not built for them is a challenge, and some people find ways to stay with the trouble. And one of the primary coping strategies is building community. So the quotes on this slide are about what doulas get from these organic connections that they make with other doulas. Some of the other women I went to training with, if I had a question, I could text them and they're like, oh yeah, I would do this. And I didn't even think of that, you know? So I think everything, the support of everybody coming together and making everything happen, like all the time, all the hands making it happen. And another doula said, one of the things I have really enjoyed is actually working with other people where we have different strengths and we balance each other. And that's one of the things I love about my work life, is working in groups like that and, you know, really appreciating what different people bring to the party. So we've got part of it that's about how doulas support each other. And the other part is how the program supports them and how they co-create the program. There's so much support with their peer reviews and the reflective supervision thing that people can talk about what happened and what can make it better and maybe explain why certain things happened the way that they did. I think that's all invaluable. And also I think sometimes because we work together and we just didn't have that before the program, you know, you've got your training and you're out there on your own flying solo. Another doula said, I like that a lot of the trainings are community led. Like I was asked to do a training and I enjoyed that. I know that there's been a lot of improvements in the program because of the whole doula-led, doula-initiated thing where we're valued. So this is an intentional philosophy of the program, because from the very beginning, doulas are told that the leadership team is responsible for writing grants and bringing in the money, and navigating the state bureaucracy and billing for Medicaid. But the program is what the doulas make it. They are the program. The ownership that the doulas have in leading the trainings and telling the program leadership what needs to change or what can improve is an intrinsic part of the program's success, what it makes the truly community-led program that it is. Thank you. So now I'm going to hand over to Holly, who's going to draw all of these threads together.
Thank you, Ruth. I will definitely say that this program feels like we planted a seed in a broken system. It's been growing and growing, and I'm so happy to see that. I was working with Dr. Cheyney earnestly at the inception of this project, and it's been a pleasure to see it change over time and grow. And that really relates to this concept of staying with the trouble from Donna Haraway, right? She's a multi-species ethnographer and multi-species feminist, and she's thinking about how we can stay with the trouble of living and dying together on a damaged earth, and that it will prove more conducive to the kind of thinking that would provide the means to build more livable futures. So that's how we're bringing this together in terms of thinking about staying with the trouble from her perspective. And so in summary, we've got a few things that we want to highlight here. And so becoming a traditional health worker and a doula in this program has really shaped their experiences, not only as doulas, but how they see the work, right? They came into a program where they had a lot of initial support, good connections for referrals, training, and things that you don't typically see in other types of doula training programs. And so this helped them become very motivated and ride on that energy. But we also had support systems in place to some extent when they were starting to hit those walls as well. And so that's when we see sort of this transition from being in the honeymoon phase when all those doulas are coming together and being trained and feeling really excited about doing this work, to getting to that part where you're like, I love doing this work, but it's not necessarily compatible with my life, especially if it's going underpaid, right? So $700 is, or $750 is still underpaid for the amount of work that these birth workers do. And so we see that with the second theme in particular, is being underpaid is a big part of it, in addition to dealing with the struggles of trying to integrate doulas into a system, or even in a place like Oregon that's relatively progressive around doula cares in terms of supporting them through Medicaid. And we have our own barriers to making sure that we build those strong relationships with the hospital and that the doulas are respected in that space as well. And then finally, with the third theme, building community, I would say that was probably the most characteristic part of this whole program. It wasn't just doulas who were serving the people that they represented in their own communities, but it was also building a community of doulas to support each other. And that was really important when we think about these pieces of transitioning and hitting the brick wall and also sustaining the work. So as you can see down here, we kind of use the wave analogy to describe this, and that the community was a really key part. Both the community doula program and the community doulas themselves have been part of riding the wave in terms of the highs and lows of doing this work, and also navigating our own Medicaid system in terms of supporting these families in a sustainable way. Missy, Victoria, anything you'd like to add? Okay, thank you all.
Thank you.